Yes, I've got a case that I need some help with. Is that okay? BG, a male aged 12, first presented aged 8 with daytime urge incontinence, occasional fecal incontinence and nocturnal enuresis. There was a family history of nocturnal enuresis in the father until age 12. Medical asthma, bowel diary showed constipation, uroflow, voided volume 63 mils with a normal curve, peak flow of 12.3, no residual on bladder scan. Time and volume chart showed 20 mils to 100 mils voided volumes. His diet was adequate, but his fluid intake was very poor. We put him on urotherapy. I also started him on some ditropan and some lactulose, and he had a physiotherapist assessment. The physiotherapist saw an overactive abs with bearing down. He achieved some lift with queuing, but nil endurance, and he was given some pelvic floor exercises. 6 months after initially, daytime soiling and wetting had gone, but he chose not to try an enuresis alarm for the night time, and he stopped the ditropan. 2.5 years later, he represents, now aged 11, urge incontinence and nocturnal uresis, even though he's using an alarm. Uroflow had gone up to 159 mils. He now had a tower curve, residual volume of 50 mils. Bowel diary, we got an abdominal x-ray which showed fecal loading, and I did a rectal diameter ultrasound which was within normal limits. We've added melatonin into the mix for nighttime and lactulose, and he's on ditropan as well. I also then added in minirin, and he still isn't going very far.
Do you remember all that? Gosh, I can't. It's very complex. Does anyone want to go?
He's not emptying his bladder yet. Sorry. He's not emptying his bladder. He's got dysfunctional voiding, yeah? So I would be looking at his bowels, and I would then be looking at his habits and behaviours and seeing what he's doing mostly. So he got himself to a point where he was managing things well. The night time during the day, correct? He was clean and dry. So he can function normally. The nighttime stuff could just be a sleep problem, but he's got either a small bladder or a vulnerable bladder that hasn't been well supported. He might have got constipated, got out of good habits and spiralled down.
I'm trying to summarize it before I... So you're talking about a boy who's now 12, whose primary ongoing complaint is enuresis. Is that correct? And it has relapsed after 2.5 years after you got him dry.
We got him dry in the daytime, and we got his bowels under control, and he's still working at night. But it's basically non-compliant to coming back, and then they represent 2 years later.
You have someone who's not emptying his bladder well for no obvious reason and has relapsed with enuresis. So I agree with what Gail just told you, but I think at some point you have to think about whether we are missing a true urethral problem or spina bifida occulta. These are the patients. These are the patients where you need to start thinking a little outside the box.
I would sort of disagree with you, Annie. I think if the child had always never completely got better, absolutely, I think it is important. And I'm not sure from Margaret's history whether that might be the case. If the child never completely got better, then I think it's really important to make sure you haven't missed anything like spina bifida occulta. But if the child actually got completely better and then relapsed, and at the point of relapse there's 1,000 things going on, then I think I'd just simplify it first before I jump straight into let's do the CT MRI story. If I saw this kid, I would say firstly to the mum and the kid, you are overwhelmed, aren't you? This is terrible. All these things is going on and it's not working, and you're trying and it's not working. And then I would probably break it down into one thing at a time. So there's a number of things going on. He's got overactive bladder, he's constipated, he's got dysfunctional voiding, meaning he's not emptying properly. He wets during the day, he wets at night. He doesn't know when he needs to go to the toilet. He's on all these other drugs, which also may have side effects. And nothing's happening, and he's frustrated, and probably so is his parents at the age of 12. So I probably break things down and just focus on one thing at a time and look at what matters most to them. I suspect the key is actually bowels, but what you need to do to say to these families is, I'm going to start you on a bowel program. It's not going to make you dry. My first aim is to get your bladder bigger, or get you to empty your bladder properly, or to get rid of the bowel symptoms so that your bladder is working better. And I'm going to demonstrate that by doing a time and volume chart now as baseline, and put you on a bowel program, and then do it again in a month's time to see if your bladder size is bigger. I would kind of build the story of how we're going to get dry. You're not going to do it in one go. First thing is you need to get his bladder emptying. Second is you need a bladder that's big enough to hold a wee in overnight. Thirdly, you need to teach him to wake to wee. So I'd break it right down, otherwise it's just too much for these kids. Any other comments? Sukanya? Yeah, don't forget the renal ultrasound and all those basic things. Thank you. Yeah, mustn't forget that. Any comments?
I was just going to say it's a lot of it's just teaching a child to listen to their own body messages. So he achieved it in primary school, probably with a lot of parental support, and he's 12. Is he going to high school? You know, it's a time where year 6 is a busy time. Kids have camps. They're more interested in what's going on in their lives than looking after their bodies, peer group stuff. There's always something else going on. And if you can sort of find out what's going on and what they do or what they like to do, then you can often find the clues. So they might be far too busy playing and doing other things and not going to the toilet regularly, so their brains are not listening to their body messages, and they've been born with a small bladder. You're not got a magic wand, you're not changing it, you're just teaching them to learn to look after their body and for things to integrate. Oh, they're busy. They get exhausted. They're way too busy, some of the Scout families. They're out every weekend and they don't get sleep. So, you know, I mean, it's great, but you look at the whole lifestyle.
Okay, probably one more, and then it'll be, is Karen Waters here? Yeah, so Karen's been sick. She's been in hospital and very sick, and she promised to come and do our talk for us. So if she's not here, we can keep talking. Karen, is Karen here? Nigel wants to ask a question. Yeah, can you find if Karen's here? No, maybe one of my team who's not at the front. Any of my other team here?
This question's for Caroline. So some older boys or young teen males on alarm training, how do you manage nighttime emissions for young boys or older boys? Because presumably that can stuff up your alarm.
She normally calls me. You can't help that one. Basically, if only I had a male in the team, which sometimes I did, I'd just kind of tell them this is facts of life. Also for girls too, sometimes when they've got just not so much even periods definitely, at least periods are timeable. You can just do minimum when they have periods. But sometimes girls, when they just have vaginal discharge, can set an alarm off. So that becomes problematic. The only thing you can do, I think, is probably to use something like a bell and pad alarm rather than a body-worn alarm, because there's a potential for a little bit more space between the emissions and the sensor. And hope that the emission is containable in the undies. Now, we've been banging on about if you do bell and pad alarm, you should be naked waist down so that the alarm goes off straight away, and that is generally true. But if you get to an adolescent and they're willing to do alarm training, and often they aren't, you might have to compromise that and do a bell and pad alarm with undies on. That's what I'd do. or use Minrin.
Not in this case, but I think the previous case was interesting, not because Patrina disagreed with me, but how many of us have seen enuresis relapse in teenagers? And what proportion? I personally think it's a pretty uncommon situation. So you need.
Come to you, Annie.
There isn't anybody else at the moment in Hunter in the public system to go to. But I think whenever the situation is abnormal, just thinking outside the box doesn't hurt. I did not say we would do CT scans or cystoscopies. All I was saying was we should think outside the box, because I haven't seen very many teenagers who are dry relapse only with nighttime symptoms. You're saying that he's completely well in the day.
So, Annie and I are very good friends, so don't get this wrong. I think they do. I think there's a lovely lady in the audience called Glenys Wilson, and she's from Western Australia. Welcome, Glenys. I found her thesis. She's a retired nurse, and she did a thesis 2 years ago on the lived experience of young men with enuresis. And I've had the pleasure of reading her thesis, and it's amazing. And the problem with why you don't see young men who represent with enuresis is they're too embarrassed to turn up. They are there, I see them. They often can't even talk to their families about it, let alone to a health professional. And they're certainly not going to come up to a paediatric unit and say they've got this problem relapsed. You know, it's bad enough first time round, but when you got fixed and then you wet again, that's really, really bad. And their parents are probably saying, you got there before, so what's wrong with you? And often what's wrong with them is they're just adolescents and they've just let their treatments slip. And you can get them back there, but this is where you need the psychologist, because their motivation is right down and they're just feeling pretty bad about themselves. So I think they do exist, but I totally agree with Annie that anytime you see a case that's outside the square, you've got to really think about it and just not assume it's normal. And I totally agree, that's true. Yeah. I think Karen is not here. She's not going to come. Oh, so apologies. That just gives us 20 minutes to ask a question, which is probably good. So we might just keep going if that's all right with you.
Hello, my name's Catherine Wiles. I'm a paediatrician in Armidale, which is halfway to Brisbane. And my question relates to the philosophy of the whole clinic. Went to an amazing talk by a family therapist about diabetes, and he said, you may have thought that you're bringing your non-compliant teenager to me for me to fix him, but in fact, I'm going to train your parents. And I can see from what the physio said there is some individual child treatment, but for a lot of the younger children, what do you think of this, that you're actually training the parents and the whole clinic? The child has the appointment, but in fact you're training the parents.
Well, hello. So yeah, I would agree, and so that's why we don't ever do sessions with just the child only. It's always the child and the parents, and sometimes the child is particularly young, and then a lot of it would just be coaching the parents to coach their kids with doing the program. So a lot of the strategies like behaviour management and setting up reminders and prompts and things like that, part of that is upskilling the parents to be able to help their child.
The way we talk about it is to say, this is a child's problem, and it's not.
Can I just add something, Melissa? Actually, I mean, it is about educating and training parents, but, and the talk was parental perspective, so we went on that strain, but it does involve the child. So I wouldn't agree that the philosophy is just training the parents. The child is there. They are listening. The talk is directed at the child, and I would generally start by saying to the family and the child, speak up and tell me anything you need to, interrupt me at any point if you have to add something. So the expectation is that the child is there, listening, contributing, and they are. And I find that no matter how young, some of it can be directed at their level, and they do get it. So it's how you pitch the talk. So a lot of it is pitched at the child, and a lot of it is pitched at the parent and the child. And as I said, in the end, it's making sure that the child has got some take-home messages. I know in the clinic they've used diagrams to show them how the bladder works. Gail does the ultrasound. So with the parents looking, but the child also listening, and depending on the age. But yes, it's not just directed at the parent, because one of the things I would tell the child is that mom and dad are there to help you. I can tell you what to do, but you're the one who needs to go to the toilet when you need to go. You're the one that needs to drink. So it has to engage them and involve them. How you do it depends upon their age and development.
Can I just say, you've got to use child-friendly language and appropriate language. Most 8-year-olds have got no idea what their bladder is. So if, they've been to multiple appointments and they still don't know what their bladder is, how are you going to actually get them to engage in a urotherapy program?
My name is Pankaj Garg. I'm a pediatrician as well. My question relates to, is there any difference between the type of alarms, like the body-worn alarm and the bell and pad alarm? Is there any difference in success rates? Because most of the families have to buy these alarms, and once they have committed to buying one, it's hard to, say that, is there any difference?
I'm currently updating the Cochrane Systematic Review on Alarm Therapy, and there is some studies that compared body-worn alarms with bell and pad alarms, and the answer is no, there's no difference in success rate. However, if you look at preference, patient preference is higher for the body-worn alarm, maybe for the reasons that they don't have to do it naked. So they prefer it, but they both work just as well. There are some families that suit to the bell and pad, and in particular, children who are developmentally delayed, where really it's mum that wants them to be dry at night and they're not that fast. A bell and pad alarm takes a long time, but it works better because they haven't got something in their pants, and basically it's the parents waking them up when their bladder is full and teaching them to wake up at that point. So in that group, I think bell and pad alarms particularly work. Generally, most people, girls in particular, prefer the body worn just because of the, being able to wear clothes.
Sorry, I'm a relatively new pediatrician and I inherited a very complex case recently. She's a 6-year-old girl with Waardenburg syndrome and had a quite traumatic event in the life. Dogs were involved and she's back with the parents. She has primary and nocturnal enuresis and daytime incontinence as well, and fecal incontinence as well. And she has been tried on various therapy. So I have just started with counseling for the post-traumatic event she had and the treatment of constipation. Am I right, waiting for those to work and then start working on voiding regime and daytime incontinence, or how to approach this case?
I think it does get a bit complicated when there's previous trauma involved, and particularly if it's secondary enuresis as a result of trauma. And I think that it's kind of multifold. So addressing the trauma is definitely going to be important, but there may also be particular bits that you can still continue on with the urotherapy or bladder bowel program in conjunction with the trauma. And I think part of that is getting an assessment to see what's preventing them from doing the bits of the program that would need to be done, and how much of that is trauma related versus how much of that might be just simple anxiety around the toilet, or whether it's motivation or forgetting, and how much of that is the trauma related stuff and how much of that is the other bits that I was talking about. And I think addressing both of them would be useful.
ICCS recommends that you treat daytime wetting before you treat bedwetting, and generally that's true. But in my experience, sometimes when you treat daytime wetting and they're not completely dry yet, but their bladder size is normal. Sometimes treating the bedwetting and getting them dry at night gives them the motivation to then address the daytime if it's quite complex, and there's sort of psychological other things as well. So very rarely, so not commonly, very rarely, I wouldn't wait till the daytime wetting is completely resolved before treating the night wetting. You need to judge each family individually, I think.
Did you say Waardenburg syndrome? So you've excluded Hirschsprung's, I assume?
Yeah, I've just been told I can't sing, so I'll talk instead. I've got two questions bringing from the one case. The first one is a very quick one. How do you assess a child's keenness or true keenness to use the alarm? I've been caught by just the one case that I'm about to share. Usually what happens is when the child is keen, I'll come up with a demo kit and I'll go through the demo run with them. They all love it, go home with a smile, and they're pretty much successful afterwards. But this particular boy, he was very keen at the start, at 8 years of age. So we went through the demo kit, he went home, he was responsive within the first 2 weeks. Parents came back, or mother came back with the diary. He wet less in amount, he wet less in frequency. But for some reason, perhaps it's because of school holiday, the family's gone on holidays, went to grandparents' place, he stopped using the alarm consistently. So it's on and off, on and off. But he still continues to have ongoing improvement. So instead of wetting at 2 or 3 a.m., he would now wet at about 5 or 6 a.m., smaller in amount. The last couple of times I reviewed him, it was a battle. Mother and son's been arguing about the ongoing use of the alarm. Parents are very keen to keep going, but he just refused to use it. It's become a battle. So what do I do next with this child?
Neil.
So your question at the end was, what do you do now that he's not wanting to, but the mum is wanting to continue? I might answer that in a second and then address your kind of first question about how do you know whether the child is keen and ready. And part of that might be doing a bit more of a thorough assessment about their motivation to do it, and bringing up potential barriers that people would face commonly with it, so potentially like winter, being cold, camps or holidays or those kind of things, and then addressing and problem solving how to overcome some of these barriers if they were to come up. And I think through doing that, you get a bit better sense of whether they're actually keen or whether they're just saying yes, 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 I'm ready or not. When the parents are more motivated than the child, I'd love to give you a quick, simple answer that would fix everything. But I think that part of that involves working with the child, and this might be one of the opportunities to speak to the child alone, to get a sense, outside of the parents, what's going on for him, and then working out what are the bits that he's facing that are preventing him from doing it. So it might be a matter of some comorbidities in terms of depression or anxiety, which might need to be addressed alongside, but there might also just be sometimes kids are needing a bit of a break, and I say that looking at Petrina. Some kids might need a bit of a break, whether it be through Minoran or just, in some extreme cases, might need to just stop completely and then restart, knowing that it's, kind of starting from square one again. But just kind of thinking through and problem solving different options and presenting that to the child, to the family, with the consequences or outcomes of it, and then giving the ownership to them and getting them to decide based on that.
I explain that every time you wear the alarm and the alarm goes off and you wake, that's one step forward towards your goal. Once you're on the journey, every time you don't wear the alarm and you're wet, or you wear the alarm, it rings and you're wet and you don't get up and go to the toilet, it's 2 steps back. I actually had this kid who presented after 6 months of alarm training, just not going anywhere. And when we got her to plot her progress, like on a snakes and ladder thing, we realised she just never got past go because she'd wear the alarm for 2 nights and then not wear it for a night. And it doesn't help. In fact, it actually desensitises the brain from alarm training. And it's usually at that stage I'll say to the parents, look, maybe it's time for a break. And I'm really into breaks. So if we can give them a Minorin break, that's great because they stay dry. Sometimes it doesn't work because they've just so not done anything else that they've gone backwards. But there's no point doing alarm training unless your kid's on side. Most kids, if they don't really want to do it, will sabotage it, and it'll just be frustrating for everyone.
And using some motivational interviewing strategies might be a useful bit for the child, and that what it involves is presenting, getting from the child their reasons for doing it, reasons against for doing it, and then putting that together and then coming up with what they want to do. And in some cases it might just be when they're ready. So we have a particular boy who just for a number of years just wouldn't want to try alarm training and wouldn't persist longer. It got to a point where he realised he was going to finish up, he's going to be 18, finish up with the children's services here and then go into adult services, and he knew that he was going to get more effective treatment here, and he just decided, okay, now's the time, and he decided to do it then.
I always tell the kids I see that alarm training's horrible. It's not fun and it's really hard work. So because if they're wetting every night, everyone's got to wake up every night. It's a real drag. And I think an 8-year-old will say, yeah, I want to be dry, I'll do the alarm training, but they don't understand the practical implications. So the wetness sensor teaches you to hold on initially at night. So typically the first 2 weeks are hard work. If you can break through that, what we see is by week 3 or so, they get a better response. It might not mean that they're not dry every night, but a good response could be instead of letting everything out of your bladder, so you would expect big, large wets initially, as they learn to hold on, to respond quickly to the alarm, to change their sleep arousal, they hold in, so the wets become smaller. And as long as they know that's a good thing, they're making progress, they need to just dig in and keep going, that the wets get smaller and smaller, and then they might get a dry by slipping through, then they feel that they're being successful. A lot of parents seem to equate wetting and success. They say the alarm doesn't work because we're still wet. But the alarm is working, it's a process, and it takes time, and a small wet compared to a large wet means you're responding. Your brain and body are talking to each other.
Sometimes the children will just say things to please their parents, so maybe that's something that happened. So having a good talk beforehand and ascertaining that is often, you can nip it in the bud before you get to the stage where the child then fails and his self-esteem goes down and things like that.
In this family, the mother is keen to push on because we all see the initial improvement, how responsive he is, but the boy himself doesn't acknowledge it. So my real question, I guess, is how do I prognosticate then? If we stop alarm treatment, if we give him a break, this is partially treated primary aneurysm. What's the likelihood of him, staying dry, even if he goes on a second course of treatment, say a year later? And to talk about Minorin, we did use Minorin. He came to me just 1 week before school camp. So he was tried on Minorin for the reason of school camp. He didn't respond to it. He cancelled his school camp, came back after the school camp schedule and started the alarm treatment. So he's actually refractory to Minorin.
I'm going to just very quickly finish that and then end here because the next speaker turns up. So I would say that it's important to talk to the parents talk the parents out of alarm training if the kid's not keen. And I would say to the parents, you're not going to succeed and it's going to be frustrating for you and frustrating for your child and it would wreck your relationship. You're got nothing to gain by pushing alarm training when he's not ready for it. And I would say to the child, you can stop alarm training now if you want, but I suspect you're going to get worse, and he will. And so when you're ready to deal with it, I'm here for you and be there. No judgment. Yeah.